All right, so let's go ahead and begin our panel discussion. So, Daniel, I'm actually going to start off with you. If you wouldn't mind, if you could just briefly share your personal journey as someone living with type 1 diabetes and chronic kidney disease, and especially as being a kidney transplant recipient.
Yeah, sure. Thank you. It's great to be here. So I will try to be as brief as I can be. So I've been living with type 1 diabetes for over 27 years. I was diagnosed at a relatively young age. I really struggled during my teenage years. Looking back, I experienced diabetes distress and diabetes burnout. But at that time, I didn't know what it was. But it just had this real it took its mental toll on me, and my relationship with my type 1 wasn't as good as it could have been. um, and that led me to the point of saying, well, if you need insulin to stay alive, so if I just take insulin and don't manage my levels, I'll be okay. Obviously we all know that that's not how living with type 1 diabetes works, but that's what I thought. So fast forward through my early 20s, to mid 20s, and that's when I first started to notice, or first started to experience some complications. So I'm currently living with diabetic retinopathy, and then in 2013 I was diagnosed with chronic kidney disease. um, Prior to that, my kidneys were um, were leaking protein, but because of how my relationship was with my type 1 diabetes, I didn't really understand what it was or what that meant kind of longer term. And I think that's an important part of the discussion that we have, is how you manage type 1 diabetes and the complications that come along with it. And if you don't have knowledge in one area, it may not necessarily um, move into another area, and you have to educate yourself. And so from 2013 onwards, it was just about, my main focus was managing the chronic kidney disease. And in 2018, I was very fortunate to receive a kidney transplant from a family member. I didn't have dialysis. I was about 2 weeks away from needing to go through that whole dialysis process. I managed to work up until the Monday of before I had my transplant on the Wednesday. I finished work on the Monday, went to hospital on the Tuesday, and then had the transplant on the Wednesday. And since then, the transplants has been transformational for me in terms of my quality of the life that I'm living and what I've been able to do. But I do know, and I'm speaking here in the UK, I'm very, very fortunate to have had a family member who was a match and was able to be a to donate their kidney to me.
Wow. Well, thank you so much for sharing that. Wow, that's amazing that you had a family member that was a match. I'm sure we're going to have a lot more questions for you, but right now I want to actually ask Dr. Ogerson a question. Dr. Ogerson, are there differences in a person's risk for chronic kidney disease depending on if they have type 1 diabetes or type 2 diabetes? And also, how do age and length of diabetes affect the risk for CKD?
Well, thanks, Janet. And yes, there are some differences between type 1 and type 2. Sadly, people with type 1 are probably more prone to kidney disease, but beyond that, it tends to progress at a more rapid pace than in people with type 2. But having said that, no one with type 2 diabetes is immune, so to speak. So everybody needs to really pay attention to their kidney function, to the proper screening tests, which I think we'll probably hear about in a little bit, so that we can treat early. Now, certainly as we get older, and this applies to people with and without diabetes, sadly, the one thing that medicine hasn't been able to solve very well is the process of aging, because we all are subject to that. And certainly after 30 or age 40, we all start to lose nephrons. And nephrons are the filtering units of the kidney. And so age affects kidney function, even if a person manages to stay healthy. But you add conditions like diabetes or hypertension on top of that, that plays a role as well. And then the other aspect that's related to progression is control of glucose. As Daniel just mentioned, he didn't pay as close attention in his teenage years, which I think is sadly kind of common among teenagers. But hyperglycemia is also harmful to the kidney. So age plays a role. How well we treat our risk factors clearly influences how quickly the kidney can progress. As I mentioned, the age part, we're all subject to that, but there are still things that we can do to help slow that process and protect our kidneys.
Great. Thanks for that. And then, so I guess with these risk levels in mind, what are the different screening tests, lab tests, et cetera, that people with diabetes should know about that can help catch these conditions early?
Yeah, and I agree. Actually, patients really need to be aware of this. And one could always go to some of the different national foundations to find out what are the guidelines related to screening, or not just screening, but actual treatment of these diseases, whether it's hypertension or diabetes, or in this case, chronic kidney disease. So the first thing that we need to look at is what's called a glomerular filtration rate. We abbreviate that E for estimated glomerular filtration rate, EGFR. In the old days, we used to do 24-hour urine collections. We'd collect patients' urine for 24 hours and then do some measurements. Not exactly practical nor fun. So now we use laboratory measures to calculate how well the kidneys are functioning, this GFR. And there are various pieces of the laboratory tests that we use to put this into an estimate, and different formulas. So that's the one thing that people do, I should say clinicians do fairly commonly, whether people have diabetes, the most common reason for chronic kidney disease, second most common being hypertension. And of course, our patients with diabetes often have hypertension as well. So clinicians are pretty good at doing a GFR test once a year per the guidelines. But what sometimes they forget to do, and this is where you as a patient with diabetes really need to be aware, is looking for protein. And Daniel touched on this about proteinuria. His kidneys were leaking protein. And this is important for your clinician to actually measure once a year at least, because protein not only can help us make the diagnosis of kidney disease earlier when the kidneys are filtering just fine. If they're leaking protein, that is a clue that the kidneys are sick. It's actually a marker. But beyond that, what our clinicians sometimes forget is that protein in the urine is actually contributing to or causing ongoing kidney damage. So therefore, it's important that our clinicians not only measure the filtration function, the GFR, but at least once a year, they should be getting a spot urine. You just, in the office, they send it to the lab and they measure the amount of protein. I'm not talking about your very sensitive measure and you can't quantify it, which is important for us from a diagnostic perspective. So those are the two main things. There are other measures where we actually look at what's called sediment, things that might be in. That's something that nephrologists do. It may come back and report. But those two things, if you know those two things, GFR, urine protein, and make sure your clinician does that once a year, that's going to go a long way to finding kidney disease early. And when you find it, then instituting treatment early, trying to avoid those complications, one of which Daniel mentioned already.
Thank you. And I agree. For all those people with diabetes that are listening, the healthcare team, we try, your healthcare team should be ordering these tests, but definitely advocate for yourself. If they haven't been ordered, make sure you do ask about them. So Daniel, I'm going to turn it back to you and ask you if you wouldn't mind sharing your personal experience with being screened for chronic kidney disease and kind of what the process was like for you and what maybe you wish you knew beforehand that you think others should know.
Yeah, sure. So from what I can remember, it was very much about having a urine test and seeing if there's any protein in my urine, and a blood test as well. And that was kind of it. And it was only really when things progressed and the diagnosis of chronic kidney disease was there, then that's when I started to understand what EGFR meant and what creatinine meant and what all of these other bits of information meant, because now I was diagnosed with chronic kidney disease. So if I look back, I think for me, it would have been good to really understand why I'm having and really understand the why I'm having these tests, what this means, what this could mean, but having that conversation in a way where it's not almost like making me feel scared of what could happen, but from a place of I want to educate you about what this means for you, what this can mean in the future. And just to widen up the answer to the second part of your question, I think if you're somebody living with diabetes and you're here today, I can, and I know you mentioned about advocating for yourself, but I would also say go and educate yourself about your kidney health. Go and educate yourself and understand what your blood pressure, what readings can mean and the impact that can have, what cholesterol can have, your glucose level and how that the long-term impact. And don't be scared of what could happen in the future, because it's better to know now and to be aware and have that knowledge and be really informed. And if I look back, I wish I had some knowledge there, or knew what, really understood what was going on when it came to my kidney health, and not to be scared of it, and speak to peers as well who have gone through the kidney experience, and to have an understanding of their experience as well.
Yeah, I think that's so important. It's really a good reminder that it's not just about ordering the test, but we need to educate people about what they're meaning and why we're getting them, and that we care. It's not coming from a place of, oh, this is a scary complication you might get, but it's coming from a place of caring and trying to protect the kidneys and other organs. So next, I'm going to turn it over to you, Dr. Eckel. I'm wondering actually if we're going to shift gears just a little bit and talk about triglycerides. So for our viewers, if you wouldn't mind defining, okay, what is a triglyceride and kind of what are normal triglyceride levels? And then also we hear a lot about lifestyle changes in diabetes care and what lifestyle changes people with diabetes can make to reduce their cardiovascular risk and address their lipids and triglyceride levels. But if you can just talk to us a little bit about how often should these be checked, what's normal, when to suspect any signs or any kind of abnormalities?
Well, thanks for having me, Diana. You've asked me now 8 to 10 questions here that I'm going to try to deal with sequentially. So triglycerides are a form of fat, and you may not like it or not, but your fat tissue is filled with triglycerides. And but triglycerides are an important fuel. I think when we don't eat for prolonged periods of time, or even when people have poorly controlled diabetes, they're releasing a lot of these triglyceride fatty acids from adipose tissue, and they cause some insulin resistance and can affect metabolism in a major way. Now, the issue of triglycerides, in terms of their level and the relationship to heart disease, is a fairly controversial topic. But let me do my best here. The American Heart Association and the American College of Cardiology have defined hypertriglyceridemia. That means your plasma or blood triglycerides are too high, somewhere between 175 and 500. So that's what they call an abnormal triglyceride. Most people use 150, and that's what I use in practice. But basically, triglycerides, when they're elevated, give rise to a disturbance in lipoprotein metabolism. Now, what are lipoproteins? Those are the things in the bloodstream that carry the fats that we absorb from the diet, and also carry fats that the liver produces. And we think of lipoproteins mostly in terms of cholesterol, because cholesterol is really what relates mostly to cardiovascular disease, meaning heart attack, stroke, and death from cardiovascular disease. Now, triglycerides, when they're elevated, give you a clue that something in metabolism has gone awry here. When they're elevated, either they're being overproduced by the liver, or alternatively not cleared very well by an important enzyme that my whole career has been involved with, lipoprotein lipase. So ultimately, when triglycerides are elevated, that should give the healthcare professional an alert to find out what factors may be involved, including genetics, or, as you alluded to, Diana, poorly controlled diabetes. And many people with poorly controlled diabetes do have elevations in their triglycerides. Now, we define triglycerides further when they're above 500. And what the American Heart Association and the American College of Cardiology calls those patients is severe hypertriglyceridemia. I have a little bit different opinion, which is really meriting what other societies have indicated, that between 500 and 1,000 is moderately severe hypertriglyceridemia, and above 1,000 is severe hypertriglyceridemia. Now, those terms are kind of pejorative, meaning they could be discussed a lot as to what normal and abnormal is. But when triglycerides get above 500, we get concerned about another risk other than heart disease that relates to triglycerides, and that's acute pancreatitis. And so when they get above 500, the physician or healthcare professional must take steps then to lower the triglycerides. And we typically say below 500 at that point in time, Diana.
Great, thank you. You did a pretty good job of answering most of those questions. I am going to follow it up with what, you kind of manage, you mentioned about if diabetes isn't well managed, that can contribute. What lifestyle changes, like what are in people's control? Like what can they do to help lower their triglycerides if they are elevated?
Right, good question. I think obesity itself causes a bit of hypertriglyceridemia. It's not clearly as extreme as it is with patients who are obese with type 2 diabetes. And that's true of most people with type 2 diabetes. They do carry an excessive amount of adipose tissue. In that setting, there's more insulin resistance, there's more overproduction by the liver of triglycerides, and the triglyceride levels tend to be higher. So, what can you do? Losing weight's a great thing to do. And I want to caution both the patient and the healthcare provider not to only measure triglycerides when people are actively losing weight, because all of the lipid levels fall during active weight reduction. You want to measure them after weight is stable for maybe a minimum of 6 weeks, but typically at 3 months. And if the weight is maintained at a lower level, the triglycerides typically come down. In terms of the diet, probably simple sugars are one thing that we should avoid patients to stay away from. But keep in mind, for patients with diabetes, we don't want them taking a lot of simple sugars anyway. And in general, the nutrition guidelines indicate that we all should be eating less than 10% of our calories as simple sugars. So reducing simple sugars such as sodas and candies and other things that have a lot of icing on them, let's say birthday cakes and cupcakes and things like that, those should be avoided to some extent to help lower triglycerides. And the final thing that we should, maybe two more things, being physically active helps a little bit lowering the triglycerides. And that typically is related to some of the weight loss or body compositional changes when you exercise more. Typically, you lose a little fat when you exercise more, but you build a little lean tissue then too in the muscles and other tissues. And that relates to the lowering of triglycerides. But the important thing I want to relate to is alcohol. We know that alcohol in a dose response curve, that means the more you drink, the more the impact on triglyceride metabolism to increase the triglycerides. So avoiding alcohol altogether is absolutely essential for people's triglycerides are above 500. And if you're lower than 500, maybe just one drink periodically. So we want to keep alcohol consumption under control in people that have high triglycerides for sure.
Thanks. I think those are some excellent tips. Dr. Mehta, I'd like to kind of loop you in a little bit. So we just heard a lot about triglycerides, but I want to ask you what you wish maybe all people with diabetes knew about the other lipids, like about HDL and LDL related to their cardiovascular health, and what role do lipids play in cardiovascular health really for all people with diabetes?
Great, Diana. And I'm sorry, I'm having connection issues, so I kind of disappeared for a few minutes. So that's a great question. And we know that diabetes per se is associated with elevated cardiovascular risk. So we have older studies that have shown us that a patient with diabetes has the same cardiovascular risk as a person without diabetes who's had a cardiac event. So we know that diabetes by itself increases your risk. And then many people with diabetes have these lipid problems that we've just been discussing with Dr. Eckel. There's a tendency for triglycerides to go up, possibly cholesterol to go up as well. And that adds to this cardiovascular risk. So patients with diabetes really do have to be aware that it is really important to measure their lipids at least once a year in order for them to be aware of what their risk might be. Now, when we talk about the individual lipids, right, the main target of treatment is still the bad cholesterol, right? It's the LDL cholesterol. That's what your physician will focus on initially. But of course, as we've been talking about triglycerides as well, we know that in diabetes, there is a tendency for triglycerides to go up as well. So one of the targets we tend to use, particularly in diabetes, is something called non-HDL, which kind of takes into account this risk of having both cholesterol and possibly triglycerides elevated as well. Now, when we're thinking about how to manage lipids, we've talked about diet. So diet is really important. Dr. Eckel has gone into how managing foods that may raise triglycerides, and also obviously keeping fatty foods down as well, because that can impact the LDL. And we know as well that patients should be really aware that they should be on statins, okay? So that's also the first line treatment in our patients with diabetes to manage their lipids. We have studies from many years ago. One particular study, the 4S study, actually analyzed the patients with diabetes in the study and found that, and they were using simvastatin at that stage, which is one of the really early statins. And they found that the patients with diabetes who are on the statin had a 55% lower risk compared to the non-diabetic patients who also showed benefit, but the benefit was about a 30% lower risk reduction. So it's just to basically emphasize that statins in patients with diabetes are effective. So now, as part of the guidance of management, we do need to have them on statins. So I think, back to your question, more than anything else, Danielle and even patients with type 2 diabetes, lipids are like a pillar of the treatment, and we need to manage them with diet. We need to manage them with statins, and there are also newer drugs coming in that will be of even greater benefit in order for patients to get to their targets. And the targets are cholesterol, LDL, and also non-HDL as a secondary target. I hope I've answered your question. I kind of went about it in a roundabout way.
That was fantastic. No, that was so good. That was so clear. And kind of continuing on that path. So I heard you talk about statins. I want to ask about some of our other drugs. So specifically SGLT2 inhibitors, GLP-1 receptor agonists. So we know now that there's several options out there for people with diabetes to protect both their kidneys and their heart. And so I'm curious, what are your current recommendations and suggestions for managing both chronic kidney disease and cardiovascular health, especially in light of all these new advances in diabetes care?
So that's a great question. So, we've looked at managing cardiovascular risk and looked at managing kidney disease risk in our patients with diabetes. And the only medications we had available in the past were things like statins to manage this cardiovascular risk. And also we used to, and we still do, use ACE inhibitors and angiotensin II antagonists. And both of these are drugs which help to manage the blood pressure. And we know that these will also help with the risk for chronic kidney disease. So in the past, really, those were our two main go-to drugs in order to help our patients with diabetes. But now we've had these two newer classes being introduced in the last few years. And in particular, let's start with SGLT2 inhibitors. We've had a lot of big studies looking at the effectiveness of this class in patients with type 2 diabetes. And it's shown benefit with respect to reduction in risk for hospitalization for heart failure, and it's shown benefit in reducing progression of chronic kidney disease. So it's not just been useful to manage glucose and to manage, as we know, it has a little slight benefit on blood pressure control and also weight, but it's also shown benefit with respect to heart failure and chronic kidney disease. And also with respect to, in general, MACE outcomes, which is what we talk about when we're talking about cardiovascular outcome trials. So they've shown this benefit very, very clearly. And they've shown this benefit not only in patients with diabetes, but also in patients without diabetes. So this class is currently being recommended for patients who don't have diabetes as well. Now, if we go to the GLP-1 receptor agonists, so they've also shown benefit with respect to cardiovascular outcomes in these big trials. But recent data has also been coming out because they've looked at the possible benefit of this class in patients with kidney disease as well, and in patients with heart failure. And they've shown recently a study called FLOW, which was carried out in patients with diabetic kidney disease, showed benefit, and it was prematurely stopped because it showed benefit. And there's also been a recent study published in patients with heart failure using this class of drugs, and there's also a benefit there. And just recently, literally 3 or 4 days ago, there was a study published showing the benefit of GLP-1 receptor agonists in persons without diabetes but with obesity, and it's shown benefit with respect to reducing cardiovascular outcomes there as well. So basically, both of these classes are now, I think, becoming pillars of treatment in patients with diabetes. And I will not be surprised that in the future, there will be standards of care in our patients. Right now, they've been specifically reserved to reduce risks in patients with these kind of outcomes, such as cardiovascular outcomes and kidney disease. But I think more and more we're beginning these classes a lot earlier in the management pathway of our patients to try and reduce the risk of these complications in the long term. So when you were talking about how I would manage patients with chronic kidney disease, so we've talked about the fact that these agents are available for our patients, but we need to take a step back before we even begin these agents. Lifestyle management is essential. So we need to educate our patients so that they're on an adequate diet, so that they're doing adequate exercise, they're not smoking. And then we need to control the other risk factors that are often present as well. So glucose, obviously, because they have diabetes, blood pressure, lipids. And then we have these medications that I've just mentioned, the SGLT2 inhibitors, which are generally first line now, at least recommended in the KDIGO guidelines recently, and also the GLP-1 receptor agonists are second line in these patients. And then finally, the third pillar of management is really ongoing support to allow patients to really continue managing their disease in an adequate fashion.
Well, thank you. I mean, it's really impressive, all this new data that we have with the SGLT2 inhibitors and GLP-1 receptor agonists. But I like what I'm hearing you saying, though, is lifestyle is still a foundation, and they really go hand in hand. It's not one or the other. So I want to actually go ahead now and turn it back to Dr. Eckel to ask a question. And that is, I'm curious about, we just heard about the SGLT2 inhibitors, GLP-1 receptor agonists. We heard about statins. Could you discuss with us any recent breakthroughs or developments in the treatment of lipid-related disorders and what maybe implications these findings would have for patient care?
Well, I first of all want to agree with Dr. Major that statins really are indicated in most patients with diabetes. There's some controversy in patients with type 1 diabetes. Their LDL cholesterols are typically pretty normal. And treating a patient with a statin who has type 1 diabetes, say in their mid 20s, is often a controversial issue. And that really needs to be discussed with the patient for the rationale. Unfortunately, in type 1, we don't have those randomized controlled trials we do in type 2 to really turn to evidence-based medicine in terms of when to prescribe the statin. But let's focus on LDL cholesterol, because I think that's where the benefit of modification of cholesterol really relates to outcome benefit. And I like what Dr. Mehta said in terms of non-HDL cholesterol. That really takes into consideration levels of HDL and also triglycerides. So when you subtract the level of HDL cholesterol from the total cholesterol, you're dealing with the particles that potentially cause cardiovascular disease, particularly hardening of the arteries that relate to stroke, heart attack, and death from cardiovascular disease. So let's look at non-HDL cholesterol. Ultimately, statins are mainstay and fortunately tolerated by most people. But when not tolerated, or the LDL or non-HDL cholesterol needs to be lowered further, we have other agents. Ezetimibe, or Zetia, is a compound now through clinical trials has been shown to be additionally beneficial in lowering LDL cholesterol. And interestingly enough, that benefit may be preferential in people with diabetes. That's still really based on one major trial, but I think there's some increasing evidence that ezetimibe may carry a little bit more benefit than equally doubling the statin dose or tripling the statin dose. So keep that in mind, you practitioners out there. Secondly, a recent drug's been approved called bempedoic acid, which has somewhat of a different mechanism. And sometimes that drug can be compared or joined up with ezetimibe to combine the two. And that can result in up to a 35 to 40% LDL cholesterol lowering. And I think how much LDL cholesterol lowering in people that are high risk or with existing disease, we're thinking about 50%. So sometimes with a low dose statin and ezetimibe plus bempedoic acid, we can achieve that 50% lowering in LDL cholesterol or non-HDL cholesterol. Then there's a whole new class of drugs which are injectable. These are the PCSK9 inhibitors. Now, these drugs are more expensive. And by the way, the SGLT2 drugs are expensive, and so are the GLP-1 receptor agonists expensive. So there's an issue at times about access to many of these medications or affordability, but we'll leave that for further discussion. But all that aside, people whose LDL cholesterol or non-HDL cholesterol is not lower enough, we think that adding these other drugs, the oral agents, bempedoic acid or ezetimibe, and for some patients, the PCSK9 inhibitors may be beneficial. So that's the LDL cholesterol story. Let's turn to triglycerides. And I think triglycerides and their relationship to cardiovascular disease remains pretty controversial. I kind of view, and this is my opinion, but I think it's supported by a fair amount of data now. I don't think triglycerides cause atherosclerotic cardiovascular disease, but I think they're associated strongly with risk for cardiovascular disease. And it's the cholesterol content that remains in the particle that carries triglycerides that ultimately, when the triglycerides are cleared from the bloodstream, that particle still has a lot of cholesterol in it. So that's where the association occurs, I think. Triglycerides being elevated are associated with lipoproteins that have cholesterol in them also. And these so-called remnant particles, that's a term that has kind of reached the healthcare professionals to some extent. These particles are pretty cholesterol enriched, and they come from particles that had a lot of triglycerides. I think that's where triglycerides relate to cardiovascular disease, associated but not causative. But with triglycerides in the range of, let's say, 150 to 500, some patients may deserve lowering of the triglycerides, some not. And the reason I'm being ambivalent about that, if we look at many trials now in which drugs used to lower triglycerides have been implemented versus a placebo to see whether cardiovascular disease events have been reduced, basically the answer is no relationship between triglyceride lowering and cardiovascular disease outcomes. In fact, many of the fibrate trials, those are drugs like fenofibrate and gemfibrozil. These drugs typically, even if they have reduced the amount of events that occurred, the relationship to triglyceride lowering has not been there. And one of the more popular trials discussed in this space is called REDUCE-IT. And REDUCE-IT used omega-3 fatty acids, which are concentrated fish oils. And in REDUCE-IT, they made a more synthetic form, which is more purified form of one of the fish oils called EPA. That trial was successful in high-risk patients and reducing cardiovascular disease events. But again, the relationship between reduction in cardiovascular disease events and triglyceride lowering wasn't there. Now, in patients who have triglycerides above 500, a fibrate or omega-3 fatty acid should be added. But there's a whole class of new drugs that have a variety of mechanisms that differ. There are drugs that block the transcription, that means the production of a protein called ApoC3. And if we look at genetics and we look at causation based on clinical observations, ApoC3 is a predictor of bad outcomes that relate to high triglycerides. So these drugs that inhibit ApoC3 by modifying their production reduce ApoC3 levels, and they dramatically reduce triglyceride levels. These drugs are undergoing trials right now to look at their effect in lowering triglycerides, both in people with familial forms of very high triglycerides or more genetic etiologies that are not simply the deletion of one gene that relates to very, very high triglycerides. Then there's a compound called angiopoietins. They come in a wide variety of flavors, not like kind of like Baskin Robbins, but they're angiopoietin 3, 4, and 8 seem to be related to having hypertriglyceridemia. And there's one drug in that space that's been marketed as an antibody against these angiopotens that is approved for homozygous FH. That means 1 in a million people have an LDL cholesterol that's very high, like 700. It's approved for that group, but that drug also lowers triglycerides. And there are also these drugs that block the synthesis of the angiopotens, and ultimately that lowers triglycerides a lot. All these drugs, by the way, are very new agents undergoing clinical trials at the present time. And I'll just close with one other lipoprotein that deserves a little attention. And I think Rupa and Ted and maybe Daniel have heard of this. This is called lipoprotein small a. Now, many physicians feel that lipoprotein small a should be measured in everybody once. There are others feel that maybe that's not indicated just in families that have a strong family history of heart disease. But the lipoprotein small a is a form of LDL cholesterol that is a little bit different in its composition and has a funny protein called apo-small-a connected to it. The concern about LPA, not only does it carry a lot of cholesterol, but it also can affect clotting and also is associated with inflammation, both things that relate to cardiovascular disease. There are multiple trials, I would say 3 or 4 now, ongoing with agents that lower lipoprotein small a in a major way that may impact the natural history of cardiovascular disease. Is that preferential to diabetes? I don't think so. Patients with diabetes typically don't have higher LPAs than people without diabetes, but people with diabetes have more residual risk than people without diabetes, and lipoprotein small a may be a very important player in that space. Now, finally, I said finally once before, but I'll make one other comment. HDL cholesterol levels do relate to risk for cardiovascular disease, but we don't know anything that relates to drug development where changing HDL cholesterol has been beneficial. However, the best way to change HDL cholesterol is lose 10% of your body weight and get physically active. So I'll just leave those messages with you, Diana, and let others carry on the conversation.
Well, thank you for that. Wow, I didn't realize there's so much research in this space, and it's amazing. I do have one follow-up question, and that's just, I know a lot of people are concerned with these drugs that is it possible their LDL will go too low or their triglycerides will go too low? So can you tell us, is there a danger if it goes a little too low?
Well, with the PCSK9 inhibitor trials, which have used 2 different drugs, the evidence that we have thus far is getting an LDL cholesterol too low is not harmful. That relates to a wide variety of potential side effects, including cognitive impairment. The brain likes a lot of cholesterol, and in fact, you lower it too low, the thought is maybe people aren't going to think as well, but that's not been shown. However, I might just give an anecdote here a little bit. If you look at the LDL cholesterol lowering that produces the maximum attributable risk, that means how many events occurred, it's around 40 to 55, in that range someplace. So I don't think healthcare professionals should be lowering LDL cholesterol to 10 or to 15 milligrams per deciliter. Right now, there's no risk that we know of that's associated with that, but the benefit from these PCSK9 trials maximizes between 40 and 55. And I think for the very high risk patient, that's where we should be.
Great, thank you. I think that's reassuring for a lot of people. So Dr. Okerson, I'd love to hear from you again. If you can just talk a little bit about the benefits of SGLT2 inhibitors that extend even beyond the glycemic control to protect the kidneys and the heart. Oh, I think you might be muted.
Of course. That's a great question, and something that, I talk about all the time, because way back in 2014, when this class of drugs, the SGLT2s, were first brought to market, we thought they were just diabetes drugs. Boy, were we wrong. And so now what I try to get clinicians, patients, and perhaps we need to get our insurance companies even to understand, these are actually cardiorenal drugs that just happen to lower glucose if you have diabetes, is the way I phrase it. The first thing I want to mention, though, kind of to your question, is the labels have been changed very recently to that it's very relevant to our type 1s. Because when you use, and you can use an SGLT2 in a type 1 diabetic patient, but the problem there is because people with type 1 do not make any insulin, they are at increased risk of developing diabetic ketoacidosis. So it used to be said, well, we should avoid them in type 1. Well, now the labels say not recommended in type 1 for glycemic control. So why does it specify just that? Because now we have found that you can use it for this class of drugs in type 1 patients for chronic kidney disease and for heart failure. And that really helps from a clinical perspective, give our physicians, our advanced practice providers, much more confidence in being able to treat the entire spectrum of patients with diabetes. The second thing that I think is of interest, and kind of to your point, your question, is also fairly new, and that is these drugs used to be contraindicated, which means don't use in people who are on dialysis. Well, that is no longer the case. That contraindication has been removed. And so now even the guidelines allow us to not necessarily start in dialysis, but clearly people progress over time. No matter what you do, some of us progress. They can still be continued even on dialysis. Now, why would that be? Because the kidneys are, for all intents and purposes, non-functional. So clearly there's no further benefit of SGLT2s for the kidney. Well, that's because these drugs still benefit the heart. And there are a lot of studies where we're trying to really figure out all the details, because what these drugs do is block a certain receptor in the kidney, and that's how they lower glucose. Those receptors aren't on the heart, but yet there are heart benefits. So why is that? Well, here I'll just outline a couple that I think are pretty interesting. One is there tends to be a decrease in the fat surrounding the heart. And by reducing that fat, that reduces inflammation. It reduces what we call oxidative stress. And those processes are harmful to tissue. And they have a whole lot of other things that they lead to that can cause damage. There's also data that the SGLT2s as a class block what we would call fibrosis, or the infiltration of certain of these inflammatory cells into tissue. And also improving the distensibility or the relaxation or the flexibility, if you will, of some of the filaments of the myocardium. This improves a portion of the cardiac function we call diastolic function and the relaxation component. There's also evidence that these drugs impact certain ion channels, what we call sodium channels, that then reduce the risk of certain abnormal heart rhythms. And in fact, that may be the mechanism by which these drugs seem to impact cardiovascular events, particularly cardiovascular death, by reducing these rhythms, which can sometimes lead to death. So those benefits in the heart are present whether people have functional kidneys or not. Some of the other mechanisms is interesting. At least we have some data, and they've been seen in a number of studies now, that actually not just a reduction in cardiovascular events and cardiovascular death, but these drugs have also been shown to reduce what we would call all-cause mortality, which is like, what? We reduce death beyond cardiovascular? How do these so-called diabetes drugs do that? Well, we're still figuring that part out, but it's been seen in multiple studies. What we have learned so far is that there seems to be a reduction in death due to severe infections, and even a bit of a reduction in death due to malignancy. Now, this is all very preliminary, so I'm not going to make any conclusions based on this, but the data are the data, as we say in science. And what we have understood is that this reduction in inflammation, reduction in fibrosis may actually play a big role as to why it can reduce death due to infection and malignancy. And I'll give a quickie example for patients. COVID is something that we've all gone through. It's been on top of, and it may be even still on the top of a lot of people's minds. Well, what we've understood, for example, in people who are hospitalized with COVID, is that they get this overwhelming cytokine storm, and that's what leads them to kind of go downhill. Well, what we've observed is by minimizing some of this inflammatory response, people are able to hang in there longer and respond to therapy and actually recover. So this is all still somewhat new, but yet I think it's still very exciting, because here, like I said, in 2014, we thought, oh, these were just diabetes drugs. Some of these factors also play a role in the heart. In the kidney. And they also, as I mentioned earlier, protein is a big deal. Having protein in the urine, these drugs reduce proteinuria. And so going back to that screening question, it really relates to why we need to be screening people with a GFR and looking also at a spot urine for protein. Because if we find those things, we need to be treating early, even if the GFR is normal, because we know that just the presence of proteinuria leads to cardiovascular risk, leads to faster progression of kidney disease. So finding these conditions or these markers early allows us to use drugs like SGLT2s. And as Dr. Maida mentioned, the other thing we could add is a GLP-1, because both of those compounds work great together. They address a much broader spectrum of some of the risk for cardiovascular events, but they also both reduce proteinuria. And I'm sure I've forgotten things because there's probably at least 14 or 15 different mechanisms by which SGLT2 inhibitors affect the heart and the kidney. I do want to add one more point, and I want to give credit to cardiologists because they came up with this first. But in their guidelines back in 2022 to treat heart failure, they said something very interesting. They said if a person has type 2 diabetes and cardiovascular disease, so in other words, they've had a heart attack, they've maybe had a stent, or they've had a stroke or a TIA, or they have multiple cardiac risk factors, there is level 1A evidence, which is the highest we can give a compound, that these people should be on an SGLT2 inhibitor. And I think Dr. Maida pretty much implied this. And now the diabetes guidelines kind of address those and agree with those cardiology guidelines. So as Dr. Maida mentioned, these drugs, SGLT2s and GLP-1s, are so good at reducing not only risk, not only good at treating diabetes, helping weight loss, but all these mechanisms and more that really help to improve the health of our patients.
Amazing. Well, thanks so much for describing all that. I mean, I remember when these drugs first got approved about 10 years ago, and it's just so fascinating to see what's happened. I remember at the time we were actually nervous about potentially damaging the kidneys because they worked on the kidneys. And now to think how far we've come and how they protect the kidneys. And it's just, I don't know, it's so awesome.
I actually should make a point since you mentioned that the GFR, we talked about that, the filtration rate. When people get these drugs, some folks will have a lower rate than when you started the drug. And some people then get nervous about that. But it's been looked at and it's actually physiologic and protective. And so the way I explain this to patients, and I think this is probably valuable for this sort of forum, is that, you know, people's kidneys, when they have kidney disease, may be working overtime. In fact, even diabetes, they can work a bit of overtime. And just like any of us, if we constantly are working overtime, we are going to wear out faster. So when these drugs are given, the numbers, if there's overtime, no overtime, the kidney numbers won't change. But if the kidneys are working overtime, it's going to take away that overtime. So the GFR may go down, but that's where they should be to begin with. It's protective and the kidneys are going to last longer. So that should be reassuring to patients, particularly the engineers who graph all their GFRs and graph all the labs that we do, that these are actually protective. Don't worry if the GFR goes down a bit when you start it. It's actually a good thing.
Yeah, that's great guidance. So Dr. Maida, I'm going to actually turn it back to you and switch gears just a little bit. If you could talk to us a little about how race and health inequities may contribute to people's risk for cardiovascular disease or kidney disease.
So that's a really great question. And I think it's really relevant in the part of the world where I practice, which is in Mexico City. So here, yes, there is a lot of health inequity. We find that about 60% of the population probably has access to public health care, but about 40% doesn't have any access or very limited access. So then, of course, it's not just the management of the disease that will be affected, because obviously they may not get sufficient follow-up if they do have diabetes, but also access to medication, right? So it becomes an out-of-pocket expense. And as we've already mentioned, these newer agents are expensive. Although I do have to mention that in the public healthcare system, some of these agents are now available, and there's even one generic SGLT2 available as well. So that does things are moving in the right direction, but there is still a lot of health inequity and a lot of problems for patients to get the care that they need. So, I think it's both things, right? It's the general control, the management, the follow-up of patients who may not have access, and then access to medications to help them care for their disease. And also, obviously, education. They're not going to have as much education if they're not having access to the healthcare system. So, it will have an impact. And as a result, complications, healthcare costs to the economy will be a lot greater, a lot more direct and indirect costs to the patient. And when I refer to direct and indirect, direct is a patient with diabetes maybe falling ill because they're so uncontrolled and needing to, maybe need access to dialysis because their kidney disease has advanced and things like that. But there are also indirect costs, which is time off work for that patient or for that person. He won't be able to support his family. So then there are those indirect costs to the community and society in general. So, this all has such a great impact.
Yeah, I mean, we need to work to try to reduce these health disparities. Could you talk to us a little bit about how you navigate culturally sensitive discussions about food and its impact on triglycerides, for example, with your patients, especially in the context of dietary preferences?
That's also something I come across almost on a daily basis in my clinical practice. So we've already talked about the foods that tend to impact triglycerides, and those are the carbohydrates. So, sometimes patients aren't aware of that. They actually think that it's the fats because, we're talking about lipids. So when I ask them, how do you think you should, reduce your triglyceride levels? A lot of them will tell me, well, I'll cut out all the fatty foods. And I'll say, well, actually, it's more than that. And in Mexico, as you can imagine, a lot of people have quite a high carbohydrate diet. It's tortillas, it's beans, it's rice. So then to turn around as well and say, well, you're going to have to take care of that as well, can be quite difficult because these are obviously the foods that are most accessible to the majority of the population. They're low cost, and as you already mentioned, they're something that's very common in the culture. So here again, education, education, education. I do find I have to sit down with patients and actually, maybe tell them, okay, it's not that you can't eat any of these foods, but you need to know the size of the portions. You need to increase vegetables. That is another issue. This is quite a meat-based culture. So tacos and things like that are very common. So to actually say, well, you're going to, it would be better for you if you increased your vegetable intake and reduce some of these excess carbohydrates. And the other aspect here in Mexico, we're one of the highest consumers of soft drinks as well. So I've got an anecdote there. My gardener was working one day in the garden, and I actually asked him, shall I bring you out a jug of water? It's quite hot. And he actually said, no, I don't drink water. And but do you have Coca-Cola? And I actually had to say, well, actually, no, I don't have Coca-Cola. I just have water. And he goes, well, it doesn't taste of anything, so I don't drink it. I prefer soft drinks. So, educating patients and the population about, simple water is probably the best thing to drink, showing them that maybe soft drinks are not the best option. So education again comes down to it. So, I think that's the only way I can approach it with my patients. A lot of patience and a lot of talking and giving them alternatives and referring them to a nutrition specialist, because that's the other thing that sometimes is not done as often as it should be.
Well, thank you for that. I feel like your patients are really, really fortunate to have you. So before we close out the panel discussion and kind of go to our audience questions, I want to turn it back to Daniel. And Daniel, is there a message or a key takeaway that you'd like to share with people who may be living with or at risk for both type 1 diabetes and chronic kidney disease regarding the importance of regular screenings and just proactive health management?
Yeah, before I do that, I just wanted to go back to the previous point around culturally kind of sensitive information, and something that was really big for my kidney journey. So I'm from an African Caribbean background, and there's a lot of hidden salt when it comes to seasoning on food. And I had to really change the type of seasoning that I was using and the amount of seasoning throughout this whole kind of CKD journey. And that was a challenge for me because it was almost challenging my cultural identity as well.
Yeah.
And I think that's almost an indirect cost as well, that another mental challenge that you have to go through. But to answer your question, I get education and really understanding why you're having these results or why you're having these tests, what these results mean. If you don't know what they mean, go and do your own research and come back with questions. And the more knowledge you have, the more empowered you feel. And that's your best opportunity to make better decisions. And I can say this now, having gone through everything that I've gone through and looking back, the knowledge that I have now, I wish I knew back then. And I wish I was more engaged in the conversation, challenged had a good way, just have a challenging conversation. But ultimately, it is on you as a person who's living with diabetes or living with chronic kidney disease to do the best that you can to manage your own health. And you should try to work as a partner with your healthcare professional. But really, education is just key, because and you can go and speak to peers, you can speak to your healthcare professionals. They're a reputable place. The Diatribe website, wherever you want, there are reputable places. But I can't emphasize how important education is just for you as a person living with diabetes. When you have chronic kidney disease or anything, it's so important.
Thank you so much. I think that's such a great message, and so appreciate you sharing your personal story here with everyone tonight. So I'm going to go now and answer. We got a lot of audience questions. So I'm going to start by actually I'm going to give the first one to Dr. Okerson. And so we have, it looks like we have someone, Fiona, said when she was diagnosed with CKD, creatinine was the reading they watched closely. That was 39 years ago. Why have they moved now to EGFR? Oh, you might be on mute again.
You're right. And to that point, some clinicians still look at creatinine as a measure of kidney function, and it's only partially true, because creatinine is really a measure of muscle mass. And I'll just give a quickie example. Let's say you have a 5'8", 240-pound running back who plays American football at your local university. Their creatinine is going to be a bit higher than normal because they have a lot of muscle. So it's only a partial way of measuring kidney function. So there are a number of different equations. In fact, you can look at some of the kidney organizations' websites, like the National Kidney Foundation or the KDIGO websites, and they list what components are in each of the different calculations. And that's why we call it an estimate. It's a calculated value based on your lab work, not on collecting 24 hours of urine and measuring those chemicals. So it's a component of the equation. EGFR is a bit more accurate. And I'll add one more quickie point. You may have seen in the lay press some time ago, but there's another measure called cystatin C, which your clinician doesn't typically order. But if we want a more accurate GFR, especially some of the race and ethnicity issues and the differences, by adding cystatin C to the equation that we used, we get a much more accurate GFR.
Thank you. That's a great explanation. So next question, I'm going to point to Dr. Eckel, and that is, what about management of triglycerides when you have diabetes, when you have type 1 diabetes and gastroparesis at the same time?
Well, I'm more concerned about glucose management in patients with gastroparesis than I am their triglycerides. So, I mean, this is one of the really challenging problems as a diabetologist. Gastroparesis is a variable disorder. Sometimes people have normal gastric emptying, and other times they have very abnormal gastric emptying. And I quit ordering meal tolerance tests because it could be normal, but the patient has serious symptoms, and vice versa. It can be abnormal and symptoms are fairly modest. So, anyway, back to triglycerides. triglycerides. I think, again, glucose management's much more critical, particularly in insulin requiring patients where there's a basal rate, presumably, on a pump, and then the bolus rate. So if you're not absorbing your calories adequately, the stomach is not emptying, and you've bolused for that meal, that's a real challenge. Now, if triglycerides are above 500, keep in mind that's kind of a different scenario. And those people need drugs to lower their triglycerides. And I'm going to be less concerned about their dietary intake, other than if triglycerides stay above 500, I may want to limit their intake of dietary fat under those circumstances. Carbs have some influence, and Rupa, it's more simple carbs than it is complex carbs because of the slower absorption. But their gastroparesis raises additional concern and issues. But I think, again, my primary interest is in controlling glycemic management in type 1 diabetes than it is worrying about a triglyceride that may be 220 one time and 320 the next time. That doesn't concern me too much unless the triglycerides are very elevated.
Great, thank you. And we have another question. Grace Kawahira, oh gosh, I probably just butchered that. Grace asked, is there any research to restore kidney health once it's damaged? And I don't know if anyone wants to take that one on.
Well, I'm happy to address it. Again, I think whether you're talking about kidney health or heart health, the key is early detection and early aggressive treatment of not just the kidney, but of all the risk factors. And I cannot emphasize that more strongly, that we really need to be aggressive at finding the risk factors and treating them to target or beyond to minimize the risk. Because once you've lost function, yes, we can slow it down, and yes, we can reduce some of the risk of the complications. But once you've lost some of it, we haven't figured out a way to get that back yet. So it's really important to prevent that loss in the first place.
Great point. Yeah. And we have another question. This is from William, who asked, what are the targets for LDL and non-HDL for type 1 diabetes and type 2 diabetes patients? So maybe Dr. Mehta, we'll throw that one to you.
Yeah, so for LDL in particular, there isn't really any difference in the targets between type 1 and type 2 in general. You're really talking at least a minimum LDL reduction of less than 100 if it's a patient with diabetes and no complications, really. But as soon as a patient has complications, we're trying to get to even stricter levels, definitely below 70, and even higher risk patients less than 55, as Dr. Eckel mentioned. And with respect to non-HDL, remember we calculate non-HDL by taking away the HDL value from total cholesterol, and it ends up being about 30 more than the LDL. So if your LDL is, say, 100, then your non-HDL target will be 130. If it's 70, it would be 100, and so on. So, in general, those targets are the same for type 1 and for type 2.
Great, thanks. And we have another question from Michael C., who asked, how about upstream strategies to limit weight issues and improve cardiovascular fitness so that everyone doesn't have to be on polypharmacy? So anyone want to bite that one?
Well, I'll take it on initially. We're finding that patients with type 1 diabetes nowadays have the same weight as people without type 1 diabetes. In other words, that's probably because of more aggressive glycemic control. And I think with more glycemic control, you're less catabolic. You're not breaking down tissues to increase glucose production, which seems ridiculous. But if you don't have enough insulin, the body's trying to recover from that by making more glucose. I have one kind of line that every endocrine fellow I've ever trained, I ask, if you could describe metabolism in one sentence, well, how would you describe it? And the best answer is to maintain glucose delivery to the brain. And there are so many mechanisms of fat metabolism, protein metabolism, and carbohydrate metabolism that relate to that. And in the absence of insulin, the brain still needs glucose, and it doesn't think on its own. I mean, ultimately, the liver makes more glucose, et cetera. So back to the issue. I think ultimately in type 1 diabetes, we really have somewhat of a different issue in relationship to this question. Preventing weight gain is so critically important, but very tight control where there's a fair amount of hypoglycemia, albeit not severe, you have to make up that with caloric intake. So getting your diabetes control with an A1C, let's say under 7 for most people, if there's too much hypoglycemia, weight gain's expected because you're eating another couple hundred calories a day to take care of the hypoglycemia. But this is a big challenge for our time, to maintain normal body weights or close to normal body weights in patients with type 1. And type 2, most people do need to lose weight. And that's something we as practitioners need to deal with an aggressive lifestyle approach. And of course, now with other approaches like the pharmacotherapies that were mentioned earlier, the GLP-1 receptor agonists in particular, we can see a fair amount of weight loss in many patients.
Can I just add in there that, the guidelines have changed recently to include, at least in type 2 diabetes, obesity as one of their pillars of management. And so weight management has to be something we are discussing with our patients with type 2 diabetes. Yeah. And also we have data as well that, if we get to the weight early on and we help patients lower their weight from the moment of diagnosis, we can even kind of revert the diabetes a little bit, this so-called idea of remission. But, we're still doing research into that. But the idea is if we can get that weight down from the moment of diagnosis, that is what we should be doing.
Well, an interesting comment along that line is I saw just a quick webcast from Deepak Bhatt this morning, who attended the American Heart Association meeting. And Deepak said, finally, cardiologists are going to have to consider weight management as something to control in terms of risk factors for cardiovascular disease. And that's based on the SELECT trial, of course.
Exactly. Exactly.
The cardiologists have finally come around.
So I have another, that's all great. I have another audience question for Dan, actually. And so someone said, you mentioned distress in your opening remarks, but what keeps you positive and really keeps you going?
Yeah, I think the experiences that I've had living with type 1 and also living with chronic kidney disease. But when it comes to type 1 diabetes, the biggest thing for me is letting go of that idea of perfection and being the perfect type 1 diabetic and having perfect levels all the time and just aiming for that, because that had a really big mental toll, took a mental toll on me. And also knowing that some days will be better than others and my best will look better on some days than not, and that's okay as long as I'm trying my best, and that's what keeps me positive. And in terms of what keeps me going is just understanding that I can learn more about my condition, I can do more. I know there was a question about implementing a lifestyle change, and so I never used to run. I've started last August, I started to run 5Ks, 10Ks, and earlier this year I did a half marathon. And it's just slow steps building up, and knowing that any time that's spent managing type 1 diabetes because of movement or exercise is worth it, because the benefits outweigh anything else that comes with it. And if I can do it, you can do it. Anyone can run, anyone can do it, and you have to do it. So that's kind of what keeps me positive, and also how you can implement healthy or lifestyle changes.
Oh, I love it. Thank you so much for that message. So I believe we have like 1 minute left, but I'm going to try to squeeze in one final question because I think it's important. We talked so much today about the importance of educating yourself and everything. And so in terms of that, how do people educate themselves? So if all of the panelists wouldn't mind naming what you think is the most useful resource to empower individuals with diabetes and kidney complications about kind of educating themselves on their condition and what they can do. So I will start off with Dr. Eckel.
Well, there's a lot of sources of information that are valid, and there are sources that are less valid. So I think it's important, first of all, to have a healthcare provider who really understands diabetes. For type 1, that's typically an endocrinologist. Doesn't have to be, because there's some general internists who do pretty well in the type 1 space. But in general, if you have type 1 diabetes, you should be seeing an endocrinologist. The American Diabetes Association, Diatribe, and many other organizations have a lot of information available. But make sure you go to resources that are well based on evidence evidence, and ultimately the recommendations really have strong support in terms of the types of studies that have been done. It's up to you to get educated. I think that's really very important.
Do you have a favorite resource?
Well, having been a former president of the American Diabetes Association, I would say that's the place to go. So, but there are other sources, and like how can I deny diatribe and everything they've done? So, no question the benefit there. And just to share with the audience in general, if I could, Diana, I'm living now with type 1 diabetes for more than 70 years, and I want to be encouraging to everyone listening today that you can manage risk factors and still be alive to talk about that maybe as long as I have, or maybe even longer. So each day I'm thankful to have another day of life, but I'm doing well and have most things under good control. So I just thought I'd mention that to encourage everybody out there with longstanding type 1 diabetes.
Amazing. Thank you so much for sharing that with our audience. Okay, Dr. Okerson, favorite resource?
Well, since Dr. Eckel mentioned the ADA, I'll switch over to the kidney gear here, and I would probably say the National Kidney Foundation. But having said that, I'm actually somewhat passionate on taking a team approach to healthcare, which means patients need to be an advocate for themselves and they need to be educated, as we've heard. So I would encourage you to look at guidelines. When you want to know about what are the guidelines for kidney disease, Google that and look it up, because ADA has guidelines for kidney disease in concert with KDIGA, which is an international kidney organization. The ACE, which stands for the American Association of Clinical Endocrinologists, they have guidelines which are basically the same. But if you know the guidelines, and it's really simple, you can be an advocate for yourself. And whether it's kidney disease or lipid management or blood pressure management, these risk factors, they're all out there with these national organizations, and they have patient-friendly information that you can access and be your own advocate. So I encourage you to do that.
Thank you. And Dr. Mehta?
So echoing Dr. Eckel, Dr. Okerson, guidelines by ADA, kidney organizations, cardiology organizations as well. But sometimes we can get swamped as well in guidelines. So I think the most important thing, and I think Dr. Eckel came back to this relationship with your healthcare provider. If he's a reputable specialist and you have a good relationship with him, again, they're going to be a really, trustworthy source of information. So I definitely use those. And the only other thing I would add is, in Mexico, the local societies for diabetes as well often have a lot of information for patients on their websites. And that will also be, trustworthy information. The problem is a lot of social media, the neighbor telling you to do this, friends telling you to do that. So just, try and use reputable sources. That would be my message.
Thank you. And then Daniel, any resource that you particularly like?
I really just want to echo the guideline piece as well. So in the UK, we have NICE, and I was fortunate to work on the guideline update in relation to type 1 diabetes. But knowing what is available to you and what you should be asking for is key. And it goes back to the education piece that we've all mentioned. And for me, I would say there are online communities. So the diabetes online community, I know that there's a kidney online community, but I do add the caveat of getting your information from reputable places within those communities, because at times it can be a bit like the Wild West. But the peer support is very much there to help you, and you can get answers to questions, and you can see an experience like mine, experience like somebody else's, and you can learn more about somebody's journey with chronic kidney disease and type 1 diabetes or type 2 diabetes. So yeah, I would say online community, but be very careful with who you follow and who you listen to.
Amazing. Well, thank you. I want to thank our esteemed panel so much. I know I've learned so much today. I think we kept you a couple minutes over, but I know I found it worth it. Hopefully you did, with these extra pearls of wisdom. And I want to thank the audience so much for tuning in and for the really engaging discussion in chat. So thank you so much to everyone, and have a great evening.
Thank you.
Thank you.